Hello friends, this is Dr. Bhavika here. Currently I am doing ophthalmology from RPC in AIIMS New Delhi. In this video I will be discussing ophthalmology section that has been asked in previous May and November AIIMS 2018. First question is, what is the adjuvant therapy in fungal corneal ulcer? Pilocarpine eye drops, atropine sulfate eye ointment, dexamethasone eye drops, lignocaine eye drops. So friends, the correct answer is atropine eye ointment. It decreases pain, prevents posterior synechia formation, and it increases blood to the anterior uvea. Blood supply to anterior uvea. Pilocarpine eye drop, it is just amniotic, no role in fungal corneal ulcer. Dexamethasone, it is a corticosteroid, so it is contraindicated in fungal corneal ulcer. Lignocaine, it is just anesthetic, no role in fungal corneal ulcers. Next question is, a 55-year-old male patient came to the OPD with complaint of glare during night drive. He had underwent cataract surgery 1 year back. The best corrected visual acuity in right eye 6/12 and in left eye 6/9. No improvement with the pinhole. What is the probable diagnosis? Posterior capsular opacification, pseudophakic bullous keratopathy, cystoid macular edema, and AIIMD. So the correct answer is posterior capsular opacification. Posterior capsular opacification. It is a type of after cataract which occurs after 1 year of cataract surgery. It usually occurs after 1 year of cataract surgery. It occurs due to the migration of epithelial cells from the anterior part of the lens to the posterior part of the lens capsule. Epithelial cells migration from anterior part of the lens capsule to the posterior part. So the posterior capsular opacification causes glare. Next is pseudophakic bullous keratopathy. It usually occurs after 1 month or 2 months of cataract surgery if there is insult occurs to the cornea during cataract surgery. 2 to 3 months if there is insult to the cornea during cataract surgery, and in this there is bullae formation which is a painful condition for the patient. Which is a painful condition for the patient. Next is cystoid macular edema. Cystoid macular edema, it usually occur after 3 to 4 weeks of the cataract surgery. Here friends, please note down the duration of the complications that occur after the cataract surgery. It is very important. So cystoid macular edema, it occurs after 3 to 4 weeks of the cataract surgery. In this there is fluid deposition, fluid accumulation between outer plexiform and inner nuclear layer of the retina. Outer plexiform and inner nuclear layer. AIIMD has nothing to do with the cataract surgery. So in next question is, a 65-year-old female patient with the history of chronic arthritis on treatment came with defective vision in both eyes. On examination, right eye is 6/12 and left eye 6/18. IOP is 18 mm of mercury in both the eyes. Anterior segment within the normal limit, and fundus photograph and FFA image have been given. What is the probable diagnosis? It is steroid induced glaucoma, choroiditis, chloroquine toxicity, and macular edema. So friend, this is a spot diagnosis of bull's eye maculopathy. Bull's eye maculopathy which have area of pigmentation and depigmentation. So the answer is chloroquine toxicity. The other options, steroid induced glaucoma. Friends, in glaucoma there will be optic disc changes. There will be increase in the cup disc ratio of the disc. Choroiditis, there will be whitish patch over the retina that can be visualized on indirect ophthalmoscope. Whitish patches. Macular edema, in this there will be collection of the fluid in the retinal layers of the macula. Collection of fluid. Here this is a photograph of macular edema, where you can see collection of fluid in the retinal layers of the macula. Now identify this picture, this macular hole, AIIMD, smokestack pattern, and cystoid macular edema. So friend, this is a picture of cystoid macular edema. In this there is collection of fluid collection of fluid between outer plexiform and inner nuclear layer of retina. Outer plexiform and inner nuclear layer. Most common cause is post cataract surgery. Post cataract surgery usually occur after 3 to 4 weeks of cataract surgery. 3 to 4 weeks of cataract surgery, and the treatment is NSAIDs. NSAIDs. Coming upon to the other option, macular hole. Macular hole, in this there is a full thickness defect of retinal tissue involving the anatomical fovea. This is the macular hole. Now this is the OCT picture of cystoid macular edema. OCT picture of cystoid macular edema. In this OCT picture you can see the fluid pockets that are present between outer plexiform and inner nuclear layer of the retina. And this is a picture of smokestack pattern. Smokestack pattern. It is usually seen in central serous retinopathy. Central serous retinopathy, in this there is collection of subretinal fluid. Subretinal fluid due to defective RPE function. So fluid will be collected between neurosensory retina and RPE. RPE and neurosensory retina due to defective function of pump function of RPE. Ocular manifestation of dengue or all except uveitis, subconjunctival hemorrhage, retinal hemorrhage and cataract. So the correct answer is cataract. Ocular manifestation of dengue include diminution of vision, scotoma, pain, subconjunctival hemorrhage, uveitis and macular edema. So cataract is not a complication of dengue. Identify the lesion in fundus picture. Cotton wool spots, hard exudates, Drusen and macular edema. So friend, this is a picture of Drusen. Drusen occurs due to deposition of mucopolysaccharides and lipids. It usually spares the macular area. Spares the macular area. Now coming upon the another options. This is a picture of hard exudates. Occurs due to deposition of lipids. One thing friends here you can note is they have sharp borders as compared to the soft exudates which have blurry margins. And occur due to stasis of exoplasmic flow. Stasis of exoplasmic flow. They are also known as cotton wool spots. So a 5-year-old boy was brought with the complaint of protrusion of the right eye since 10 days with no history of fever. CT scan showed well-defined mass in the orbit with irregular border and adjacent bony destruction. Biopsy revealed small round cells which is positive for desmin on immunohistochemistry. What is the probable diagnosis? Retinoblastoma, cavernous hemangioma, orbital cellulitis and rhabdomyosarcoma. So friends, here it is positive for desmin. That means it is a marker for muscle differentiation. So the correct answer is rhabdomyosarcoma. Now coming upon to the another options, retinoblastoma. It is an intraocular tumor. Cavernous hemangioma. In this there is no bony destruction. And in orbital cellulitis there will be history of fever present. So rhabdomyosarcoma is the best option. Use of stenopaeic slit or all except. Corneal tattooing, optical iridectomy, Finchamp's test to rule out the axis in astigmatism. So friends, firstly I will like to tell you what is stenopaeic slit. this you must have seen in the refraction sets. This is a stenopaeic slit which have a slit like this in the center. It is used to improve the vision on the visual axis. So the answer is corneal tattooing. In optical iridectomy, it is used to find out the axis which has maximum vision. So the axis which is having the maximum vision is a site for optical iridectomy. In Fincham's test, it is used to differentiate between early cataract, conjunctivitis and glaucoma. Now, and to find out the axis in astigmatism. The center for vertical gaze is interstitial nucleus of Cajal, nucleus of Purlia, Raphe nucleus, pontine paramedian reticular formation. So the right answer is interstitial nucleus of Cajal. Pontine paramedian reticular formation is center for horizontal gaze. And nucleus of Purlia is convergence center. It is convergence center. Which of the following is a site of lesion of internuclear ophthalmoplegia? Medial longitudinal fasciculus, sixth nerve nucleus, pontine paramedian reticular formation, A and C. So the correct answer is medial longitudinal fasciculus. Friends, in this there is weakening of medial rectus. So in this there will be defective horizontal gaze. So friends, if like this, if this is the right eye and if this is the left eye, and if this eye is defective, so the MR will not be functioning, so there will be difficulty in adduction of ipsilateral eye. And since the lateral rectus of the left eye is contralateral synergist of the medial rectus, lateral rectus is contralateral synergist of medial rectus. So if there is weakening of the medial rectus, so there will be relatively more innervation to the lateral rectus. So when if person will try to look on the left side of his sight, then the medial rectus will not be functioning, so it will lead to ipsilateral adduction failure, and relatively increased innervation to the lateral rectus will lead to contralateral abduction nystagmus. Identify the marked layer in the given histopathology specimen: inner plexiform layer, outer plexiform layer, inner limiting membrane and outer limiting membrane. So friend, this is inner plexiform layer. Inner plexiform layer contain processes of horizontal, amacrine, bipolar and ganglion cells. Now friend, this is the histopathology section of the retina. Here you can see all the layers of the retina and how they look upon the histopathology section. Which of the following is the most common ocular manifestation of Sturge-Weber syndrome? Sturge-Weber syndrome has a triad, that is port wine stain, leptomeningeal venous capillary malformation, venocapillary malformation and ocular abnormalities. Which include choroidal hemangioma and glaucoma. So the correct answer is glaucoma. A patient presented with pain, photophobia and watering from the eye since last 36 hours. On examination, there is 1 to 2 centimeter ulcer with minimal hypopyon with finger-like projection into the stroma. What is the most likely cause? HSV2, acanthamoeba, fungal keratitis and bacterial keratitis. So the correct answer is fungal keratitis. Fungal keratitis has certain features that are, it has feathery margins. Feathery margins. In this picture you can see there are feathery margins in the keratitis. There will be hypopyon present and there will be satellite lesions. And there will be immune ring of Wesley. Treatment of the fungal keratitis include natamycin 5%, antibiotics to prevent further bacterial infection, and cycloplegics to reduce the pain. What is the angle subtended by the biggest letter of Snellen's chart at 6 meters? 1 minute, 5 minutes, 50 minutes and 60 minutes. Now friends, on the Snellen chart you must have seen these kinds of letters are present on the Snellen's chart. So this portion of the letter subtend angle of 1 minute. This also 1 minute. So total will be 5 minutes. So the biggest letter at 60 meter will subtend angle of 60 meters will subtend angle of 5 minutes. So in the question they have asked at 6 meters. So 5 minutes multiplied by 10 is equal to 50 minutes. So the biggest letter of the Snellen's will subtend an angle of 50 minutes at 6 meters. So the correct answer is 50 minutes. A 2-year-old child presented to the OPD with photophobia and lacrimation. On examination, the cornea was found to be enlarged as shown below. What is the likely diagnosis? Congenital glaucoma, retinoblastoma, megalocornea, congenital epithelial dystrophy. So the correct answer is congenital glaucoma. In this is also known as buphthalmos. Buphthalmos. In this there will be cloudy cornea and hapstri. Hapstri are healed breaks in desmin membrane. Healed breaks in desmin membrane. Identify the given spectacles and their use. Progressive glasses, presbyopia, bifocal presbyopia, bifocal pediatric pseudophakia and bifocal aphakia. So the correct answer is bifocal presbyopia. In this picture here friends, you can see there is a seam present in the glasses. So the upper part of the glasses is used for distance vision and the lower part of the glasses is used for near vision, and the both part of the glasses have different power. And one thing here friends to note about it, that the seam should pass through pupillary margin, pupillary area or pupillary margin. Now the other options, progressive glasses, they have no seam present in them. No seam present in them. And in bifocal pediatric pseudophakia, they will use glasses only for near vision, not for distance vision. Near vision because they will be having no accommodation due to absence of lens. No accommodation, so we'll be using glasses for near, and for the bifocal aphakia they will be using high plus glasses lens. High plus glasses lens with no seam present in them. The given image of the patient's ophthalmological examination is suggestive of which of the following condition? Oculomotor palsy, superior oblique palsy, internuclear ophthalmoplegia and lateral rectus palsy. So the correct answer is oculomotor palsy. So in this first image you can see friends, firstly I would like to tell you one mnemonic, that is SO4 LR6. So all the muscles of the eye except for the superior oblique and the lateral rectus are supplied by third nerve. So in this, the superior oblique will be supplied by the fourth nerve and lateral rectus is supplied by the sixth nerve. So in this, in the first picture, friends, you can see there is ptosis present in the right eye. Ptosis present in the right eye. So it is occurred due to the paralysis of LPS. Due to the paralysis of LPS. And in this, the left eye is in primary gaze. The left eye is in primary gaze and the right eye is outward and downward. Outward and downward. It occurs due to outward movement occur due to action of LR and downward movement occur due to unsuppressed action of superior oblique. And in this C image, here you can see there is no difficulty in abduction. No difficulty in abduction, that is LR function is retained. LR function is retained. In the fourth image here you can see there is difficulty in adduction. In this, the left eye is trying to turn to the left side but the right eye is unable to turn to the left side. So there is difficulty in adduction due to defective function of MR. Defective function of MR which is supplied by the third nerve. And in this picture here you can see the left eye is upwards but the right eye is downwards. That is, it has inability to shift to the upward position. So in this there will be paralysis of superior rectus. There is paralysis of superior rectus. And in this image here you can see the left eye is little downwards but the right eye is not downwards. So in this there is paralysis of inferior rectus. So friends, this is all about the ophthalmological section in the last May and November AIIMS 2018. So friends, if you like my video, please like, comment and share my video, and if you have any query or doubt you can put it in the comment section below. So thank you very much and best of luck.